The United States pays more for prescription drugs than any other country. President Trump says it's time to change that, with a bold plan to tie American drug prices to those paid in Europe and beyond. But what will the so-called most favored nation policy actually do to cut costs? Or is it just going to cause chaos? Welcome to CareTalk, America's home for incisive debate about healthcare, business, and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chairman of UConn Health.
John, let's start off with the basics. What is the so-called MFN policy?
So it's a little bit unclear because the president's been for this before he dropped any interest. But the most favored nation policy would require, conceptually, that all drugs in the United States are priced at no higher than the lowest priced averaged either of the industrial West, the big countries like Germany, Japan, and the UK, or actually the lowest price internationally, which could get as low as Africa. And this could be pretty substantial. A most favored nation drug pricing requirement for U.S. pharmaceuticals for drugs sold in the U.S. could represent anywhere between a 50 to a 90% reduction in the cost of drugs to consumers in the U.S. tomorrow.
And John, this is very different than the traditional methods of controlling drug costs, which would be things like negotiation under Medicare, rebates.
Or nothing. I mean, the reality, Dave, is that for American consumers, 1 out of every 3 prescriptions isn't filled, 1 out of 3 or 1 out of 4, depending on the estimate, because prices are so high that the consumers can't even afford, even with insured coverage, the out-of-pocket costs. And so I would argue that we got a massive problem, and regardless of what people say is being done about it, consumers are still getting screwed by paying higher prices in the U.S. than any other part of the world for drugs that are created, manufactured, and priced in the United States.
So it sounds fairly straightforward as healthcare policies go. Why is it a controversial policy?
Because big pharma makes big bucks. Dave, come on. You're acting like an innocent here. Pharma has some of the highest margins of any business in the country outside of cigarette manufacturers. I mean, the margins are insanely high. Now, part of those margins are appropriately high because they are creating the drugs that are doing things like curing cancer and sickle cell, and there's an extraordinary amount of innovation that is funded by some of the margin. But because the United States has historically, the United States government, not been willing to negotiate prices with pharma, unlike any other industrial country, we are paying more and actually consuming less than folks in other parts of the world who can afford the drugs at the prices that their governments negotiate. And I'm talking about, rich countries like Germany, the UK, France, Japan. They're all paying less and for the drugs that are actually created in the U.S.
So the president is often talking about other countries ripping us off, and I think in many cases it doesn't make sense to me. You have free trade. There's countries make investments in all sorts of things, but this is an area where it seems like, maybe we are subsidizing the rest of the world.
David, of course we are. I mean, the president is completely right here that we're being ripped off. Unfortunately, it's a little bit like the taco trade. Trump always chickens out. He's already played this game in the first administration. And, perhaps, he actually came into office when he was president the last time and talked about big deals and big discounts and getting a deal with pharma. And he got nothing. Absolutely nothing. In fact, the ability to negotiate drug prices and the reduction of costs in insulin, those were Biden policies that Trump talked about in some cases during and actually made no progress as president Although when he was running for president against Biden, he sometimes would mistakenly take credit for policies that Biden actually executed on as president to reduce the prices of things like insulin. But let's be clear. The president's absolutely right here. Big Pharma has overstepped and is overcharging Americans every day. And it's because they're not negotiating with anybody. David, did you realize that drug companies can raise their prices every month? Every month. I mean, that's just remarkable when you think about the fact that they really rely on, for the most part, public dollars to create the research that funds the early development. That's from the U.S. taxpayers. They actually rely heavily on Medicare and Medicaid government payers to actually pay for the drugs. And yet they can raise prices at will. And consumers, are increasingly in the U.S. can't afford the drugs they're prescribed.
John, it is right to note that under President Biden, you had the first real progress on drug pricing in the form of the Inflation Reduction Act. Which so let's give credit where credit's due, and let's talk about how while Trump tried this in the first term, it didn't work, and why it might be different now. So the first time he tried it, there was legal pushback, there was political opposition, and it was just sort of complex to deal with. Why might that be different now? Well, one is that there's a really increased bipartisan and public pressure for drug pricing reform. You see it in the form of, I'll let you talk about some of the, what do we call it, odd partners, strange bedfellows in Congress.
Don't get into personal relationships, David.
PBMs being demonized. And then I think some of the legal and administrative groundwork has been laid from some of those, past failures. So I think there's more of a chance of it actually working. So you don't want to talk about strange bedfellows, John?
Well, let's start with the history of this. The president really is right here, and the reason why you're seeing the bipartisan movement in Congress between senators from the Republican and the Democratic side, the Peter Welsh from the People's Republic of Vermont and Josh Hawley, a very far right-wing Republican, is because both the far right, if you listen to Republican talk radio or Democratic talk radio, although that doesn't really exist, the progressive and the very conservative commentators agree that big pharma companies are ripping off the American consumer because their constituencies are feeling it when they go to the drugstore and they can't afford the drugs. So there's a lot of interest there. But the question here is whether the president really wants to push it. I mean, he came in to the administration with this as a key priority. And look, if he could deliver on this for the American people, it would be an amazing success. But Big Pharma very publicly has said they breathed a huge amount of relief when what happened is it's kind of, again, Taco Trump. We didn't see anything of a legislative nature. In fact, there's sort of an agreement to agree and conversation. And when you push on what Secretary Kennedy and Administrator Oz have talked about, it's really they're fixing to have a conversation about fixing the drug problem. And I will tell you that pharma has won this fixing to have a conversation for the last 50 years. Drug prices have gone up. It's a major source of healthcare inflation. And it's a major source of excess corporate profits, often for just the extension of patents for generic drugs. I mean, one of the major sources of large pharma profitability has been gaming the patent system, which actually in the first Trump administration, the administrators took on. So I do think there's potential real policy progress here, but based on what pharma is saying, the White House has not committed to actually pass a law. It hasn't committed to take any particular executive action here. It's just fixing to have a conversation. And I don't know, David, but that doesn't sound like real pressure to me. What do you think?
Well, John, we have all these conversations, whether we're fixing to or not, and it hasn't resulted in any prices dropping or maybe anything else. So I agree. This issue is emblematic of some broader issues. These very strongly worded executive orders do not actually carry the weight of law. And when you say 30 days, you're going to do this, especially for something that's very complicated, it's just not going to happen. And you can wait out the clock and wait for the next excitement to occur. And John, I know you accused me before of being naive, and I'm at the risk of sounding naive again. I'm not going to ask a naive question, a basic question, which I think gets to part of the challenge here. What exactly is the price of a drug in the U.S.? We say we pay more. What is the price?
Well, I think the glib answer is what the consumer currently has to pay out of pocket and what that consumer can't afford in 1 out of 3 or 1 out of 4 cases, which is super painful. But the pricing of drugs goes through a lot of twists and turns because drugs are covered drugs by insured entities. When you're getting it through your commercial health insurance, Medicare or Medicaid, are often going through the insurance company, who often outsources it to something called a pharmacy benefits manager, which is the specialty of actually negotiating with the big pharma for the insurer, for allegedly for the consumer. And because of the multiple parts of the supply chain, kind of how the drug gets from research, creation, manufacture, distribution, and then eventually to your local drugstore or through the mail, there's a lot of fingers or hands touching that drug. So the price goes up and down a fair bit, but I wouldn't be confused by that. The bottom line is that if we have a drug industry that we created, that's somehow that's getting the majority of the profits in the system on a percentage basis and sometimes in a real total dollar basis, and consumers can't afford it. We have a system that's broken and we need to fix it. But there's a lot of hands that touch drugs, David.
John, this is, in a way, I was thinking about this most favored nation as a kind of logical extension and big expansion of the idea that's been kicked around for a long time about reimportation of drugs from Canada, which is our next door neighbor, which has many of the same products, and the drugs are a lot cheaper. So this is in a way of saying we're not going to actually physically reimport them, which seems stupid anyway, but we're just going to take the price that others have negotiated.
That's exactly right. And let's not confuse most favored nation, because it's sort of that's a technical phrase from trade. This is what people are really aiming at is the fair average price for other industrialized countries. And just to be clear, the prices for drugs that are identical to those in the U.S. are 50 to 90% cheaper in Montreal than they are in Montana. And that's crazy at some level. Now, there's been a lot of interest in importation of drugs from either Europe or Canada, but the reality is there's not enough excess drug supply in those countries, and pharma controls that supply. So the minute you were to increase reimportation, and the state of Connecticut's passed a law saying that they're looking into it. Florida has been trying to do it for over a year now, but it's just a sideshow. The real question is, can we leverage the bipartisan pressure to get fair prices for the U.S. To get pharma to the table? Josh Hawley from Montana and Peter Welsh from Vermont have a bill that would say, look, we just want drug prices in the U.S. to be the average of the 6 largest industrialized countries. Like, just make sure the U.S. has a fair price. And if you want to charge more, you have to pay a penalty that's 10 times the difference between what you want to charge and what those countries have to pay. It just doesn't seem to be crazy to me that American consumers shouldn't have to pay any more than someone in London or Paris or Tokyo should pay. I just think that's just logical.
So, John, we've done a good job, I think, laying out what this policy proposal actually is and what some of the initial reaction to it is and why it makes general sense. Let's close out on a couple of topics. One, let's talk about some of the unanticipated downstream consequences of this, and then potentially how the parties are going to react besides just, fixing to have a conversation and then it's all fixed after that. So maybe starting with these downstream consequences, I've heard concern about the Medicaid rebate program and especially about the 340B program. Can you say what those are, first of all, and whether those concerns are valid?
Well, Medicaid, that's the federal state program that covers health insurance for the poorest and the disabled in the U.S. It covers about 70 million Americans. They currently have access to something called Medicaid best price, which is the best price available for um, consumers in the Medicaid program. And there's also something called 340B, where hospitals that are serving high need populations in like urban or rural settings also get have the ability to buy drugs at a very low price and then are able to get reimbursed at a higher price, and it's effectively a subsidy to those vulnerable hospitals that's paid for with the margin that would otherwise go to uh, the it would add to the excess profits of the big pharma manufacturers. And so, but I think let's not get distracted, whether it's a focus on PBMs or supply chain or 340B or Medicaid best price. Pharma keeps throwing all of these other issues in here. Medicaid best price and 340B are simply ways to shift some of the burden of the excess profits away from a system that serves the poor and back at pharma. What pharma is trying to do is just muddy the waters in the conversation. I think pharma has a legitimate argument around novel biotherapeutics that are new therapies where they should be able to charge a high price around these really novel new technologies. But 70% of the profitability of pharma in general is, standard chemical compounds, generics, branded drugs that have been out there for a while, that around which there's no novelty at all. We're just paying excess profits to the executives and the shareholders of those companies. And so I think it'd be more constructive for pharma to really make to make the legitimate argument that we have to make sure that they're paid a lot to do more with new drugs, and be honest about how they're charging too much to U.S. consumers for old drugs for which they've already been paid for multiple times.
John, I think it's very fair. I was just pointing out that there may be some surprising constituencies here that would be opposed to this. So
no, what pharma's trying to do is to, if the federal government takes money from one part of their sort of excess profit pool, to shift it away from something else where they're subsidizing somebody else who's on a government benefit. I think that's shameful, but it's not unexpected, because their attachment to their own current and future profitability is pretty aggressive. And they have the largest amount of lobbyists in Washington. And right now, you can kind of buy your way to policy, apparently. So they work very aggressively investing in DC lobbyists to muddy the waters and find new ways to make more money, even if there's some agreement on some discounts somewhere else in the supply chain. So it shouldn't surprise us, but neither should we let it distract us from what's a genuine structural flaw, where our consumers are paying too much for drugs that cost a lot less anywhere else in the Western world.
So let's talk about something that pharma might do if it gets beyond the conversational stage and this were actually to be implemented. So we talked about at the simple level, let's say there's 6 countries that you're averaging the price from. Well, right now, a country like New Zealand, I don't know if they're on the list, is a tiny country in terms of population, known to be pretty cheap about the drug pricing. Right now, say, who cares? I'm going to have not that many customers. I'd rather have some rather than not that many, and I'll just give them a low price. If all of a sudden the price that I offer in New Zealand is going to have an impact on the price in the U.S., is a pharma company going to act differently? Are they going to raise the price? Are they going to actually not participate in those markets?
I would expect that in the large industrial countries, this is where the president's really got a legitimate point. Why shouldn't people in England, France, Italy, Japan, Germany, for example, pay a little bit more so we can pay a lot less? I think that's completely reasonable. And I would expect that pharma would raise the prices abroad. But, the GLP-1s, which are really transformative drugs, cost $1,000 a month in the US and $100 a month in the UK. That's crazy. There are drugs that cost, $1,000, let's say $100 a month in New York City, that in Egypt cost like $5 a month. the pricing differential between countries that small countries, well, Egypt's not that small, but really third world countries and industrial countries and the U.S. Everybody's almost an order of magnitude cheaper on any drug, and that's crazy. But I think certainly other wealthy Western countries can pay a lot more, and frankly, that's where a lot of the drugs are going. And so I think that's where the president has a really legitimate argument. I just like him to put some muscle behind this, the way he has in on some other policies, like lowering taxes for super rich people.
Well, that's it for yet another episode of CareTalk. We've been talking about most favored nation status as it attempts to reduce the price of drugs paid here in the United States. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chairman of UConn. If you liked what you heard or you didn't, we'd love you to subscribe to your favorite service.